What we did in the Pittsburgh project, just as an example, was we generated from the hospitals monthly reports on readmissions. Now, technically that's not a really good measure because it's only same hospital admissions, but we looked at the claims data to say how good are we going to be if we simply look at the same hospital admissions, and the hospitals we were working with, pretty significant percentage return to the same hospital, so it was good enough. Don't let the perfect be the enemy of the good. Better to get rapid feedback than get the perfect measure. And then we also tracked patients in a registry by the care manager. But we also said, you know, we really need to understand when there's a failure, what happened. So we developed a special questionnaire so that when a patient came into the hospital as a readmitted patient, they were flagged and somebody went in and did an interview with them. Why are you here? What happened? What happened yesterday, you know, in the last week that led this to happen? You wait until discharge, you wait until afterwards. They don't remember. Nobody remembers. You got to find out immediately what happened. And the care manager also then looked into if one of their patients was readmitted, why was that? And we did chart reviews to try to figure out whether or not what we thought we were trying to do for the patients was actually happening. Guess what? It wasn't in many cases. So that leads you, if you try to make all this work, big challenge that you face is, so can you actually sustain this? We have lots of people now trying to do stuff about readmissions, but the problem is that the payment system fights you at every step. Because hiring those care transitions coaches, having a nurse care manager make home visits, using telemonitoring, even having the physician answer the phone whenever the patient calls is not paid for today by Medicare or most commercial health plans. So we get grants to support these efforts, you know, a little bit of money, and then the question is it going to be there in the longer run? And moreover, so are hospitals going to be the solution to come up with all the money to do this? Well, the problem is that hospitals and doctors actually lose money if we're successful in terms of reducing readmissions, because hospitals are paid based on the number of times they admit patients. Same with physicians, on the number of times that they see patients. So we've got a real problem with the payment system. So what do you do? Well, there's 5 basic approaches that you can use to payment reform. And I'm going to go through these just quickly, and I'll tell you why. But one is don't pay providers for readmissions. People have talked about that. Second is pay somebody more if they actually implement programs believed to reduce readmissions. Third is pay bonuses or penalties based on readmissions rates. Fourth is pay for care with a warranty, so you don't accept more money if there's a readmission, but you may get paid differently for it. And fifth is create a more comprehensive payment to be able to cover all the kinds of things that patients need, regardless of how many hospitalizations or readmissions. So let me just talk about each of those so you can see the challenges. The don't pay providers model, while it's been talked about, is not being used, thankfully, because for some pretty obvious reasons. Why should somebody treat the patient if you're not going to pay for them? And the patient may end up being readmitted to a completely different hospital who's genuinely trying to help the patient. And do you really want people to start refusing to admit patients because they think they are at high risk of readmission, and particularly when you can't prevent them all? So simply not paying doesn't work. The more positive approach is to say, let's pay for what we think will keep the patients out of the hospital. But there's 2 dilemmas that people face with this. And I think this will be increasingly true. So who to pay? So with everybody doing a readmission reduction initiative, are we going to pay for all of those independent readmission reduction initiatives? And if they're all trying to take credit for the results, sooner or later we're going to have lots of programs getting relatively low ROI. Second problem is, from the payer's perspective, nobody's guaranteeing any results. I'm going to give you more money. And yes, there have been projects saying that these projects work. But nobody's willing to stand behind them and say, I'm going to guarantee you that if you give me this money, I'm going to reduce readmissions. So the payers, whether you're Medicare or commercial health plan, look at it and say, you want more money, but you're not guaranteeing me that you're going to save me any money over here. How do I know that this is not going to just simply increase healthcare costs? So you get reluctance to be able to fund that. Third model is to pay hospitals bonuses or penalties typically penalties, not bonuses, based on readmission rates. Now, the problem with the P4P program, this is the simplest thing for payers to put in place. They don't have to change anything about the way they pay, just put a pay-for-performance system in place, program in place. But really challenging to be able to make this work. So let me give you an example. So let's suppose we create a pay-for-performance program that reduces a hospital's payment rate by 5% if its readmission rate is higher than average. And let's suppose that I have a hospital that has a 25% readmission rate and the average in the community is 18%. So they are subject to this penalty. And let's suppose that the hospital has 500 admissions, they have a 25% readmit rate. Let's suppose they're getting paid $5,000 per admission. Low rate, because I'm going to make this as conservative as possible. So they're generating $3.1 million from those admissions. So the P4P program goes into place. If the hospital does nothing, they end up losing 5% of that money, and it's a $150,000 loss to them. So you might say, hospital should pay attention to this. They're going to lose $150,000. But if they actually do what they're being asked to do and they get the readmissions down to 18%, they don't get the penalty, but they also don't get paid for those admissions anymore. And in my little hypothetical example here, they actually lose more money by preventing the readmissions than they would by simply taking the penalty. Now you say, well, okay, we should tweak all the numbers. But the problem is, tweaking the numbers, you got to make that pay-for-performance penalty pretty big to be able to overcome that. And if the hospital has to spend money to actually reduce the readmissions, it's got to be even bigger than that. And the bigger you make the P4P penalty, the closer it looks to we're simply not paying for readmissions anymore, and all those problems I talked about earlier start to arise. So should we actually be taking on these patients in the first place with a high readmission risk? And fundamentally, the problem with the P4P programs is there's actually no incentive to do better. So once everybody is average, we stop. Once everybody's average. Medicare has created a fairly complex workaround to this problem. It's because of the things I just described to you. So Medicare, this is now being implemented. It's in the law. They have a program that says every payment to a hospital will be reduced by 1% in 2013, 2%, and then 3%. If a hospital has excess, they are higher than average readmissions on heart attack, heart failure, and pneumonia with additional conditions to be added. Now, theoretically, this is why it got created, theoretically, this is better than other P4P programs because it actually magnifies the penalty for the readmission rate without focusing on the readmissions per se. Because you continue to pay the same for the readmissions, but you penalize the hospital overall. But you don't have to actually think about this very long to realize that it's probably not really very good policy in reality, because it's reducing the hospital's payment for all their admissions. You're basically underpaying the hospital for all the other patients that you're taking care of because they've got a problem over in this particular area. And the hospitals that have relatively few patients with those readmissions actually get the biggest penalties because it's hurting them across the board. So it doesn't create any incentive to try to work on readmissions anywhere else. It's only going to be about trying to make sure we're average on heart attack, heart failure, and pneumonia. And it doesn't do anything to try to fix the rest of the system. So as you might guess, I'm really not a fan of this particular model. So what's a better idea? Well, a better idea is to actually think about the idea of paying with a warranty. Paying with warranties sounded like a really crazy idea up until a few years ago when the Geisinger Health System in Pennsylvania started to do this. Basically, single price for everything associated with a patient's care, pre-admission, both hospital and doctor, post-acute care, and any related complications or readmissions. And they started this with bypass surgery, and they have been systematically expanding this to other things, including things that don't necessarily even involve the hospital, or aren't based in the hospital, like maternity care and back pain. And they got really dramatic improvements. 20, 40, 60% improvements in things, including 44% reduction in readmissions for their CABG patients in 18 months at a facility that was already viewed as a high-quality performer. Because changing the way they were paid changed all of the incentives that enabled them to redesign the way they delivered care. Now, the myth that has developed is that you have to be a Geisinger. You have to be a big integrated health delivery system to be able to do this kind of thing. The interesting thing is that the earliest documented example of anybody giving a warranty in healthcare was a single doctor, Lansing, Michigan, orthopedic surgeon, who said, I'm going to give a 2-year warranty on my shoulder and knee operations. Anything goes wrong, I'll fix them. It's in the literature. Doctor made more money, hospital made more money, payer paid less because they were able to redesign care and cut out all the unnecessary stuff and focus on quality without worrying about what they were going to lose under the current payment system. Now, a warranty, to understand this, a warranty is not an outcome guarantee. In other words, you're not guaranteeing that there will be no readmissions. You're merely saying that we won't get paid for them if they occur. We're not guaranteeing there will be no infections. We're simply saying we won't get paid for them. And most, if they occur, and we'll fix them for no charge, essentially. And most warranties are limited warranties. We don't warranty everything. You know, when you buy your car and it has a warranty, it doesn't say it's going to fix everything that goes wrong.